This is a presentation on SecNav instruction 6120.3. The first thing I like to do when studying instructions off the bibliography is actually break down the SSIC code for that instruction. First thing I'll notice here is that this is a SecNav instruction. Most of the instructions on the bib are BUMED instructions, so already this sticks out a little bit in my mind. Of course, it falls under the 6000 series. Anything 6000 has to do with medical, but if we look at the secondary SSIC code, the 100, right, anything that's 6100 has to do with physical fitness. And then the 2 designates it as 2 as the tertiary number. This designates it as physical exams. So your periodic health assessment is a health assessment that makes sure that somebody's individual medical readiness is all good to go. It makes sure that this person is worldwide deployable. So that is why it is categorized that way. That is why it's numbered 6120.3. So the purpose of this instruction is to establish a policy and procedures to ensure that the individual medical readiness of Navy and Marine Corps active component and reserve component service members is complete. It established the periodic health assessment as a primary tool to consolidate evidence-based preventative services, occupational health and risk screening services, health record review, special duty physical exams, and individual counseling, testing, and preventative treatment. First thing we need to do is define what individual medical readiness is. So your IMR is made up of 6 components, and those 6 components are your individual medical equipment. We'll get more in detail, but I'll kind of just summarize them real quick. Your individual medical equipment is any medical supplies you may need, like glasses and ballistic inserts and inserts for your gas mask, or any medical equipment you may need. Immunizations, right? The immunizations that you need for whatever region in the world you're operating in, or any region of the world you're getting ready to deploy in. Readiness laboratory studies. And like I said, we'll get into some more detail about these, but HIV, G6PD on file, your blood type. Your dental readiness. Dental readiness. Dental falls under your individual medical readiness, okay? Dental is a part of this. Number 5, deployment limiting conditions. Are you injured? Are you on limb due right now? Do you have a pending physical evaluation board? And then the periodic health assessment itself. Okay, so these are the 6 things that make up your individual medical readiness. That's why you can have a big SHOTX where you get your whole battalion to come in and you update all their immunizations, and your readiness only jumps up from like 72 to 75%. The reason being is, yeah, you got your immunizations up, but all your Marines and sailors, they were missing that PHA or their dental class 4. You need all these things to be ready in order to be good, in order for your IMR to be complete, to be medically ready to go. So let's talk about the PHA broadly. The PHA broadly is going to be used to review, verify, and correct IMR deficiencies. This is a tool we're going to utilize to identify things you're missing, any of those 6 things you might be missing off that IMR, and we're going to use this PHA to fix them, to correct those deficiencies. The PHA is also going to be used to verify your pre and your post deployment health assessments. And this is I'd recommend when studying this instruction that you bring up a couple other instructions that are on your bib. If the bib includes the deployment health instruction, the OPNAV 6103 alpha, I would have that instruction and study it side by side so you can cross-reference these. Because this instruction, you're going to see cross-references a lot of things that end up on our bibs. It's going to reference tuberculosis control, so we need to know about BUMED instruction 6224.8. We need to know about the physical readiness program, OPNAV instruction 6110.1. Juliet. It's going to reference pregnancy, OPNAV instruction 6000.1 Charlie. It's going to reference the manual of the medical department, chapter 15, for physical examinations and standards. So I would have all those instructions, especially if they're on your bib, side by side as I'm studying this instruction, and just cross-reference them against each other. So PHA, review, verify, and correct IMR deficiencies. It's going to be used to verify your pre and post deployment health assessments. It replaces the NAVMED 6120/3 for your reserve component. This is the annual certificate of physical condition. PHA is going to replace it for our reserve component. And on our active component, it's going to replace that 5-year physical exam. You don't have to do a 2808 every 5 years now because you can do a periodic health assessment annually. All right, and then annually, all active component and reserve component service members will receive an individualized face-to-face assessment of their health. That's what the PHA is. It's an annual face-to-face assessment of their health. And then it is considered complete when all the PHA components have been addressed, the issues have been identified, and the service member has either completed or been given a plan for with indicated referrals, counseling, and testing, meaning they came in, we corrected all the deficiencies on that IMR, and there's nothing going on with their health that's concerning, or we corrected all those items on their IMR, but they need some further they need a consult somewhere. There's something going on with their health. That's when we consider the PHA complete. When everything is done, or we've referred them to the appropriate place for testing, for further testing or counseling. With the PHA, there's a couple things we need to consider when it comes to our patient. We've got to consider the patient's age. Certain screenings start at a certain age. We've got to consider their gender. We have gender-specific health screenings. We got to look into their family history because we know that there are some conditions that people will be more prone to if they have a family history of them. We got to consider their occupation. Are they all up to date? Do they have occupation-specific requirements? Do they need a dive physical or a flight physical? So we've got to consider what they do for a job. We got to look into their deployment status. Are they pre-deployment, post-deployment? Do they have the medical equipment or the medications they need to go forward? And then we've got to look at some behavioral risk factors. We got to get a good history on these guys and see if they do things that are going to put their health at risk. Do they use tobacco? Do they use alcohol? Do they have poor nutrition? Do they have bad exercise habits? These are all things we need to consider when doing the PHA, and we'll talk about them a little bit more throughout this presentation. We've got to document our PHA in one of the approved electronic systems. We can use ALTA, the Armed Forces Health Longitudinal Technology application. We got to put their dental information, or make sure their dental information gets put in what's called DENCAS, your Dental Common Access System. We can put their PHA in SAMS, and SAMS is an acronym within an acronym. The S in SAMS stands for Shipboard Non-Tactical Automated Data Processor, or SNAP. And then the AMS is your automated medical system. So the SNAP automated medical system. And then we got to get them in MERS, the Medical Readiness Reporting System. And then in addition to the electronic system, we've got to make sure all this documentation makes it into their health record, their actual paper record. In order to have a good PHA process in place, the PCMs need to be involved in this. The PHA should be done on our active component within 30 days of their birth month. For your reserve component, you're just going to do it annually on them, so whenever they come up on their annual due date, that's when they'll do it. And when feasible, you want to try to get your PHA done in a single visit. You want to have it set up in your clinic, probably with the coordination of a couple other departments like immunizations, laboratory, and dental. But the idea to have a really good PHA program in place is that you can get it all done in a single visit, and you can get somebody's IMR 100% done and any unresolved health issues appropriately consulted or taken care of in-house. So your approved providers who can review a PHA, they're going to include the independent duty corpsmen, physicians, nurse practitioners, and physician's assistants. All right, these are the final approvers. These are the four that can review and sign off on that PHA, saying that it is complete. Let's review a little bit of what we've gone over so far. What are the 6 elements of a service member's individual medical readiness? The 6 elements of a service member's IMR. Well, we've got the individual medical equipment. We've got immunizations. We've got laboratory studies, dental readiness, deployment limiting conditions, and the PHA itself. These are the 6 elements of an IMR. In regards to the active component, what has the PHA replaced? For our active duty, what has the PHA replaced? It has replaced that 5-year physical. We don't have to do a DD 2808 every 5 years. What are some approved electronic systems that PHAs can be documented in? Some approved electronic systems that we can document a PHA in. Well, we've got Alta, we've got DenCAS for dental, we've got SAMS, and then we've got MERS. This is where we can document PHAs electronically. Who can sign a PHA? Who's got authorization to review and sign a PHA? We've got 4 positions that can do this. All right, independent duty corpsmen, physicians, nurse practitioners, and physician's assistants. They can sign off on a PHA. All right, moving on here. We're going to talk about the components of the PHA. It's going to seem like a lot of them, but we're going to get through them. So PHA, we got to do height, weight, and body mass index. We got to get a blood pressure measurement. We've got to do a visual acuity. We got to check individual medical equipment. We got to see their audiogram status. We got to evaluate their hearing possibly. We got to look into the immunization status. We're going to have to do some tuberculosis surveillance and screening. We got to look into our laboratory studies. We got to look on the status of our annual dental exam. We got to see if there's any deployment health or readiness issues. We got to see if we've got any occupational, medical, or surveillance needs. We got to do a cardiovascular risk factor screening. We got to do some female-specific health screening on our female patients. Colorectal cancer screening on a specific patient population. Health risk assessment and counseling. Physical fitness assessment. And that is it. That's all we got to do. Now we're going to talk about these in a little bit of detail. So for your height, weight, and body mass calculation, we got to weigh them, right? We got to weigh them. And this is not something that can be self-reported. We've actually got to weigh them. We're going to do a blood pressure measurement. And what are we doing? We're screening for hypertension, right? We're looking for that silent killer hypertension. And we'll talk about cardiovascular stuff a little bit later here. When we go to test visual acuity, if we find that it's worse than 20/40, or the member is complaining of decreased visual acuity, we've got to refer them to optometry. Service members who do not meet the 20/40 acuity standard, who cannot see 20/40, they will obtain and wear prescription eyewear. Our reserve components, they've got to provide an updated prescription from their civilian provider every 2 years. So visual acuity needs to be at least 20/40. If it's not, you need to go to optometry, or if you're having complaints of decreased visual acuity, you need to go to optometry. And our reserve component, they need to provide a prescription from their civilian provider at least every 2 years. How we're going to test visual acuity? Well, we've got 2 methods we're going to utilize. We've got distance binocular visual acuity testing and near binocular visual acuity testing. Let's talk about distance binocular visual acuity testing first. So this is performed with that standard Snellen acuity chart. There's standard Snellen chart. This is the one where they have you stand 20 feet away, cover one eye, read the lowest line you can read. All right, test with both eyes open, either uncorrected or with habitual distance correction, meaning you're wearing the prescribed glasses, okay? Your prescribed glasses, and we'll get into that in just a second. Record the smallest line read and document whether glasses were worn during the test. So if you typically, when you do this test, if it's somebody who does not wear glasses, you just document the lowest line they read. So if at 20 feet they read the 20th line, you say, 20/20 vision, OD, OS, OU, uncorrected. If they wore glasses, same thing, you just say corrected. With our near vision testing, well, this is who we've got to do this on service members 45 years of age or older. So if you're under 45, you don't have to do the near binocular visual acuity testing. It is performed using a near acuity card, and the distance for that one is usually 16 inches. So 45 years and older, we got to test your near vision, and we're going to do it with a near visual acuity card at a distance of 16 inches. And just like the Snellen chart, we're going to record the smallest line you can read without error. And we can't wear contact lenses when we're testing visual acuity. No contact lenses. If you have corrective lenses, if you are prescribed corrective lenses, you need to bring them to the PHA and you need to wear them because we need to see if your prescription lenses are still good. Because you're not supposed to wear contact lenses in the field. You're not supposed to wear contact lenses when you get deployed. We want to make sure that the prescription eyewear that you're going to be wearing when you're deployed is good to go. That's why we insist that you bring your glasses when we do a PHA, because that visual acuity is part of it. Individual medical equipment. Well, if you've been identified as somebody whose vision is not 20/40, you're going to need 2 pairs of eyeglasses. That's going to fall under that individual medical equipment part of the IMR. If you have the eyeglasses, you're also going to need ballistic protection optical inserts. You're going to need the inserts for your eye pro, for your eye protection. You're also going to need your vision corrected when you're wearing those. So we got to make sure that you have the inserts for that. They must be compatible with the Military Combat Eye Protection Device, the MECEP, that is issued to the service member. And not only do they have to have ballistic glasses, but ballistic inserts, we got to make sure they have gas mask inserts, okay? So we got to make sure they've got protective gas mask inserts. Also under medical equipment is going to be our medical warning tags. If you have an allergy or sensitivity or a medical condition, we've got to get you those red dog tags. That's part of your medical equipment. And then we got to ask. We got to ask, is there anything else that you have? Any other medical equipment that you may have? This could be anything like dental equipment, hearing aids, sleep apnea machines. We've got to ask during the PHA because this is a component of their IMR. Hearing. Hearing will be assessed if there is no DD2215 in the health jacket. If you don't have a reference audiogram in your health record, a DD2215, we've got to get one in there. So we're going to assess your hearing. If there's a complaint of tinnitus or ringing in the ears and it has not been addressed, you're going to get an audiogram. If no in-depth audiometric testing has been done, if there's no in-depth audiometric evaluation in the health record, and we see some things on your previous audiogram that are concerning, and we'll get into those in just a second. But if you haven't gone and seen, an audiologist, and we've got some of these changes in your hearing, you're going to go see them. All right, so if we've got a 30 decibel threshold, meaning that you are not hearing. When we say decibels, we are referring to loudness or volume. So if you are not hearing until 30 decibels at the pitches, right, at the frequencies of 500 hertz, 1000 or 2000 hertz, you need to go see audiology. If it's greater than 45 decibels, if it takes more than 45 decibels of loudness for you to hear at the high pitches like 3000, or if it's greater than 55 at 4000, then you've got to go get some more in-depth training just in a normal audiogram. So taking a look at a 2215, a reference audiogram, we've got a spot here for the left ear and a spot here for the right ear. These numbers right here, this 500, 1000, 2000, 3000, 4000, 6000, these represent the hertz, the pitch, a low or a high pitched sound. What goes in these boxes right here is the decibels, and the number they put here is the decibel that you heard it at, and the decibels the volume, it's the loudness. So if when they are putting a 1000 hertz sound through that audiogram, through those headphones, and you hear it at 5 decibels and you push the button when it's at 5 decibels of loudness, 5 decibels of volume, they're going to put a 5 right there. Okay? If they're putting a 30 there, if it says 30, well, that takes quite a bit of volume. We need to take a look at that. That needs some further evaluation. And that goes for 500 and 2000. If at 3000 you're getting past 45, well, then that becomes concerning. And then at 4000, if you're getting past 55, right, it's taking 55 decibels for you to hear it, well, that too becomes concerning. We're also going to assess your hearing during your PHA if you are enrolled. If you're enrolled in the hearing conservation program, we've got to assess your hearing. right? In the hearing conservation program, you're going to have an audiogram done every 12 months. So if you're due for it and we find that on your PHA, we're going to make sure we get that taken care of. We've got to look at your immunization status during your PHA. Any overdue immunizations are going to be administered during the PHA. Immunizations that are required for deployment no matter what, no matter where you're going. We've got a couple that are required for deployment, and I think it's a good idea to know these ones. They include hepatitis A and hepatitis B, the inactivated polio vaccine, inactivated polio vaccine, your Tdap, your tetanus, diphtheria, and pertussis. Got to protect against that whooping cough, right? Tetanus, diphtheria, and pertussis. And then your MMR, your measles, mumps, and rubella. Measles, mumps, and rubella. And then influenza. We've got to have these 5 vaccines to deploy anywhere. All right, these 5 universal. And we'll talk about it in a minute, but region specific will have requirements as well. But we need to know these 5 for deployment: hepatitis A and B, inactivated polio vaccine, Tdap, MMR, and influenza. We need them to deploy. And then, of course, additional immunizations may depend on things like your geographic location. Are you going somewhere where they've got yellow fever? Are you going somewhere where there's a risk of smallpox or anthrax? Your occupation. Certain jobs require further immunization, and then does your immediate superior in command have his own requirements, his or her own requirements? Does your ISIC have requirements? We've got to follow those if that is the case. A little bit more review. So your visual acuity, if it's worse than blank, it's going to require a referral to optometry. Visual acuity worse than blank requires referral to optometry. That is 20/40. If you can't see at 20/40, if it's worse than 20/40, you got to go see optometry. You're going to need some glasses. What is utilized to test your distance binocular visual acuity during the PHA? Distance of visual acuity. Oh, we use a Snellen chart. At what age is near binocular visual acuity tested? At what age do we have to do near visual acuity during the PHA? Well, that's when you get older than 45 years of age. Older than 45, we got to do the near vision. How far is a near acuity card held when testing near vision? 16 inches. 16 inches. If a service member requires corrective lenses, what medical equipment must be verified during the PHA? If you've got corrective lenses, if you're prescribed glasses, what equipment do we need to make sure you have? We've got to make sure you've got 2 pairs of eyeglasses, that you've got protective gas mask inserts, and that you've got ballistic protection. You got your ballistic inserts as well. What form is the reference audiogram? What form is the reference audiogram on? Well, that's on our DD2215. DD2215. What immunizations are required for deployment? What immunizations do we need to deploy? Just general deployment, not region specific. Well, we need hepatitis A and B. We need that inactivated polio vaccine. We need that Tdap. We need our MMR. And we need influenza. What are the 6 elements of a service member's IMR? 6 elements of a member's individual medical readiness. We've got individual medical equipment. We've got immunizations, laboratory studies, dental readiness, deployment limiting conditions, periodic health assessment. Those are our 6. Individual medical equipment, immunizations, laboratory studies, dental readiness, deployment limiting conditions, and the PHA, the 6 things that make up your MR. For your active duty component, what does a PHA replace? Well, that replaced our 5-year physical. We don't have to do that DD 2808. What are the approved electronic devices we can document PHAs on? We can put them on Alta. We can put them in DINCAS, at least the dental part. We can put them in SAMS, and we can put them in MERS. Who can sign a PHA? Who are authorized to review and sign PHAs? Well, that's the independent duty corpsmen, physicians, nurse practitioners, and physician assistants. All right, moving on. Another component of our PHA is tuberculosis surveillance and screening. Okay, so we have to do some screening, and I've done a presentation on the tuberculosis instruction, the BUMED instruction 6224.8 Bravo. It doesn't mention it in this instruction, but it is mentioned in the TB instruction, which is not always on the bibliography. But during the PHA, we do a screening, right? We do a paperwork to determine whether or not they need a tuberculin skin test, whether or not we need to place a PPD. And that screening that we do with the PHA is a NAVMED 6224/8. The form matches right up with the instruction. 6224/8, the interim TB exposure risk assessment. We had two other forms in this instruction. Let's see if we knew them. We got to do a form when we have a positive PPD, and then we have to do a form for monthly evaluation when we're being treated for that latent tuberculosis infection. So our form for when we have a positive PPD, that's your NAVMED 6224/7, and then your monthly evaluation once we start you on INH, well, that's your NAVMED 6224/9. So 7, 8, 9, 6224s for tuberculosis. Those are the forms for those. Part of your PHA, though, is that tuberculosis screening, that 6224/8. And if you answer yes on that, then we test you. Then we put that PPD test into your forearm. Laboratory studies. Laboratory studies as components of the PHA and the IMR. So if laboratory studies are due within 11 months, we're going to go ahead and do them. We're going to draw them on the PHA visit. Remember, we're trying to make that PHA visit a one-stop shop. So one of the laboratory studies we're going to talk about is lipid screenings. And the way we determine whether or not somebody needs to have their lipids drawn is we are going to consult the Guide to Clinical Preventative Services. And this guide is put together by the U.S. Preventative Service Task Force. And this task force, they're actually put together by the Agency for Healthcare Research and Quality, the AHRQ. And what this task force is a panel of national experts in prevention and evidence-based medicine. They make recommendations to help primary care clinicians and patients decide whether or not a preventative service is right for them. If you look right here, this is the website. All right, so like I said, the Agency for Healthcare Research and Quality, these are the guys that coordinate this preventative task force, and every year they come out and they update the recommendations for any kind of preventative screening, who needs it, what populations need it, which ones are obsolete or no good, and this is who we can refer to. And it's free off this website. You can download it as a PDF. They actually have an app, and the app's pretty handy too, because you can put in your patient's kind of demographic information. You can put in their sex and their age, and it'll let you know all the recommended screenings for that person, all the recommended preventative screenings that are required for that demographic. They'll also send you a free book. I got a free book from these guys as well. You just have to visit the website. But not only do they make recommendations for who we need to get lipid panels on, they make recommendations for colorectal cancer. They're the reason we don't do the PSA on people who are 40 anymore, the prostate specific antigen. So this is where you would get the most up-to-date reference on what kind of preventative services we need to do, what kind of screening laboratories we need to do. Then readiness studies. So readiness studies, these are labs you absolutely need before you deploy, and it should be part of not only doing your PHA and checking your IMR, but part of your pre-deployment health assessment as well. So we got to make sure that we've got the appropriate ABO blood type. We need to know your blood type and your RH factor, right? Your RH factor is what gives you that negative or positive. So we're going to give you an ABO, right? You're going to be either A, B, AB, or O, and then you're going to be positive or negative. We need to get that lab documented and in your health record. We need to know your G6PD status. That's very important, especially when we go to places that have malaria, because that's going to affect the way we give you chemoprophylaxis. That's going to affect the way we give you medication to prevent you from getting malaria. So we need to know your G6PD status. we've got to have a DNA specimen, and we've got to make sure that that DNA specimen is on file at what's called the Armed Forces Institute of Pathology Repository. So the Armed Forces Institute Repository, anybody who's been active duty in the military, they keep on file your DNA. So if something happens, they can identify your remains. And then we've got to have a recent HIV test in your health record, and it should be active duty, your active component. They're tested every 2 years unless otherwise indicated. Moving on to the dental exam. For reservists can have their annual exam done by a civilian dentist. They're going to utilize the form DD 2813. However, they do need to see a military dental officer at least once every 3 years, okay? So they can do their annual testing with their civilian dentist. They just got to get their civilian dentist to document it on that DD 2813, but they got to see a military dentist at least once every 3 years. When confirming that your dental is up to date when doing your PHA, well, we've got a couple resources we can obtain that information from. We can get it straight off of DentCaz, we can get it off of SAMS, or we can get it off of MERS. Your annual dental exam is going to classify you, or if you don't have your annual dental exam, you're going to get classified. But we're going to talk about class 1 and 2 versus class 3 and 4. When somebody is said to be class 1 and 2 dental, well, that means that they are worldwide deployable. You're good to go. You meet the requirements for your IMR. Our class 3 and 4s, however, well, they're at increased risk to experience a dental emergency. And because of that, they're not required, or they're not regarded as worldwide deployable, because you never know where you're going to get deployed and what your dental assets are going to be. So when they say you're a class 3, it means that your teeth are in such a condition that you will probably have some sort of dental emergency in the next 6 months. When you say you're class 4, it just means you haven't come in, so we don't know the status. So service members deploying with operational units without organic dental assets are expected to have an annual type 2 dental exam. That's what we call the annual exam, a type 2 dental exam that projects your dental risk status through the anticipated duration of the deployment. We want to know what the risk, what the chances of you having a dental emergency during the duration of the deployment is going to be. Moving on to the deployment health and readiness. All right, if deployed or redeployed during the current year. So when we say redeployed, it means you came home. And okay, so if you've been deployed or you've come home during the prior year, we've got to verify that you've done a pre-deployment health assessment, a post-deployment health assessment, and a post-deployment health reassessment, and we've got to make sure that those are in your record. The forms that we are going to capture these are on. Well, we're going to do the pre-deployment health assessment on the DD 2795. DD 2795. Your post-deployment health assessment, that's going to be done on the DD 2796. Now, there's a typo in this instruction. It lists the post-deployment health assessment as a DD 2795, but if you look at OPNAV instruction 61.3 alpha, the deployment health assessment, and that's the one I'd go off of, and that's the one, that one is on the bibliography. Your post-deployment health assessment is your DD 2796. And then your post-deployment health reassessment, well, that's the DD 2900. Okay, we got to know these three forms. All right, and if not completed, the member will complete them at the PHA if they're due, and we'll get into that in just a second. And then if there are any unresolved issues identified during these post-deployment health assessments and reassessments, they need to be tracked to conclusion by the primary care manager. All right, the primary care manager assigned to that patient needs to make sure that they get the appropriate referrals, and they need to track that until the issues are resolved. Reserve components, especially if they're going back into their reserve status after deployment, they're going to be referred to their NOSC, their Navy Operational Support Center, and they will continue to follow up with them. So I want to talk about the deployment health assessment process a little bit more. The instruction that we find more details on the deployment health assessment process is that OPNAV instruction 6100.3 alpha. So this too is a 6100 series because it does have to do with physical readiness. So our DD 2795, our pre-deployment health assessment, our DD 2796, our post-deployment health assessment, and our DD 2900. We're going to talk about the windows in which we need to do these. The pre-deployment health assessment, the 2795, the window for doing that is within 120 days of deployment. You don't want to do it any earlier. You don't want to do it at 122 days or, before we get here. But once we get into this window, that's when we should be looking at doing our pre-deployment health assessment, the DD 2795. The DD 2796, the post-deployment health assessment. Well, we've got a window we can do that in. We do it 30 days before we go home, before we leave the area we're deployed, to 30 days after we've gotten home. So we've got a 30-day plus or minus window that we can do this in, from what we call redeployment, going home, to 30 days after being home. The DD 2900, the post-deployment health reassessment, well, we have to wait till 90 days after being home, but we don't want to let it go any longer than 180 days. So that 90 to 180 day window, that's what makes up our post-deployment health reassessment. That's when we need to complete the DD 2900. So DD 2795, pre-deployment health assessment, 120 days prior to deployment. DD 2796, we've got a 30-day plus or minus window on redeployment. And then our DD 2900, that's our 90 to 180 days after coming home. So doing these deployment health and readiness checks during our periodic health assessment, what are we doing? We're looking for, let me get off the marker here. We're looking for some deployment health limiting conditions, or some deployment limiting conditions, excuse me. Do you have something going on that would limit you from deploying? So service members shall not be lim-due, right? They can't be in a limited duty status. They can't have a pending physical evaluation board. They can't be, waiting on a PEB. They can't be pregnant, right? And if they recently were pregnant, they can't be in a postpartum status, right? They can't be recovering from a pregnancy. And we can find further guidance on that in our OPNAV instruction 6000.1c concerning pregnancy. Occupational medicine and surveillance. So we've got to make sure that any pertinent screening and documentation is within the health record and captured on that 2766, the DD 2766. And we're going to take a look at the 2766 in a little bit here. All right, but any occupational screening, whether it be something for like a dive physical or a flight physical, there's a spot on the 2766 where we can annotate that it has been done or when it's due next. Cardiovascular risk factor screening. So when we're considering somebody's risk for having cardiovascular disease, we've got to consider some things. We got to think about their age, because the older you get, the more likely you are to have some cardiovascular disease. We got to think about your gender. We see it more often in males. We've got to consider family history. We got to see if we've got a history of hypertension or elevated blood pressure. If you've had an abnormal lipid profile, meaning do you have dyslipidemia or high cholesterol? Any history of heart disease, tobacco smoking use, and then of course the diabetes. All right, and what we're going to use, what we use for it is the Framingham Risk Calculator. All right, so with the Framingham Risk Calculator, it's going to take your age, gender, whether or not you're a smoker, your total cholesterol, what part of your cholesterol is your high density lipoprotein or the good cholesterol, your systolic blood pressure, and then whether or not you've been prescribed medication for hypertension, and it's going to calculate your 10-year risk for having coronary related disease, from having your risk of having a myocardial infarction, from having a heart attack. And it's going to give a percentage, right? It's going to say you're either, a low risk, less than 10% chance in the next 10 years of having a heart attack, intermediate, you've got a 10 to 20%, or a high risk, greater than 20%. And these scores are used to determine how aggressively to treat you, especially with medications for your cholesterol. So we plug in these values, we use the Framingham risk calculator, and it's going to give us these numbers, and we make a treatment decision based off of that. Per the instruction, it can be found in the Navy Environmental Health Center website, but the Navy Environmental Health Center is no longer a website. It's now the Navy Marine Corps Public Health Center, and it's there. That's where I pulled this from, actually. You can pull it right off the Navy Marine Corps Public Health Center. Female-specific screening. Well, we're going to find guidance for our female-specific screening in the manual of the medical department. And what chapter in the manual of the medical department are we going to find it in? Well, that's chapter 15, right? Chapter 15 having to do with physicals, right? Having to do with physical examinations and standards. And we're also going to find guidance in that in our guide to clinical preventative services put out by the United States Preventative Service Task Force. So I'm gonna talk about this a little bit, just because, again, chapter 15 is something that's always shows up on the bibliography, and it's something we should cross-reference while we're studying the periodic health assessment instruction. So chapter 15 of our P117, article 15, TAC 112. That's where we're going to find our female-specific physical standards, okay? Physical exam standards. So annually, they should be screened for obesity. Well, that's captured on the PHA anyway. Hypertension, chlamydia. They should be screened for chlamydia if they're sexually active in 25 years or younger. And you can do this through any approved method, whether it be urine, vaginal swab. Doesn't necessarily need to be a pelvic exam. Cervical cancer screening. Well, that's not the same, okay, as just a routine pelvic exam. Cervical cancer screening, that's your pap smear, and that's not annually, okay? That's first started at the age of 21, regardless of history. Ages 21 through 29 will have cervical cytology. They'll have a pap smear alone done every 3 years, okay? Ages 21 to 29 every 3 years. Ages 30 and older every 5 years. And they'll also have HPV co-testing as well. So 21 to 29 every 3 years, cytology alone, no HPV. Ages 30 and older every 5 years with a pap smear, cytology, and HPV, right? So cytology, when we're doing that, we're screening for cervical cancer. Any pap smear results, they should be provided within 30 days. Abnormal results, of course, they should be provided ASAP. A couple other things that go into the well woman exam. There should be an annual pelvic exam to include external inspection, internal speculum exam, and then the internal bimanual exam. Breast cancer screening should be done for women 21 years ages and up. They should have an annual clinical breast exam and education done. They should have further testing done if they have a positive family history of breast cancer. So 21 ages and up, they should have an annual clinical breast exam with education. And then women 40 through 75, they should have a clinical breast exam and a screening mammogram, right? They should have mammography done, and those results should come back to them within 30 days, right? Screening results back in the 30 days, but if a mammogram was done for diagnostic reasons, like a lump was found, well, that needs to come back ASAP. Okay, went off on a little tangent, but it's applicable, right? This instruction is always in the bibliography, and it ties right in. So if I were studying this section, I would have this chapter in the ManMed opened up so I can go ahead and run these side by side, maybe get a better picture of the whole thing. Colorectal cancer screening. Well, the guidelines from that, just like a lot of the things we've talked about, that's going to come from your guidelines, the Guide to Clinical Preventative Services from the United States Preventative Service Task Force. They recommend colorectal cancer starting at the age of 50. And that should be done either by colonoscopy, sigmoidoscopy, or at the very least a fecal occult blood test using a hemoccult card. Again, starting at the age of 50 through 75, some sort of annual testing. And then health risk assessment and counseling. We're going to utilize what's called the Health Assessment Risk Tool, or HART. It's now called just the Health Risk Assessment, the HRI. It can be found on the Navy Marine Corps Public Health Center. And when you go into that, when you go into the link, and I'll pull it up in a second here, when you go into it, the member can actually do it by their UIC. and then you can have a representative within the command actually pull some data, and it's unanimous. Like, there's no personal identifiable information that's put into that, but a representative of the command can use it to kind of get a snapshot of the health risks surveys that their population is filling out. And any counseling we do, we're going to capture that on that 2766. And again, like I said, I'll pull up a 2766 in a little bit here. So right here, we're looking at the Navy Marine Corps Public Health Center. All right, and this is the link to the health risk assessment tool. So what they're calling HEART in the instruction, we just call it the health risk assessment tool. But you go right here onto the link, you plug in into UIC, and then it'll let you fill out the questionnaire. All right, so pulling up our 2766. All right, we always see that right in part 1 of the record. Well, this is, and anybody who's done a PHA has probably done this already, but this is where we can document, the screening that we're doing, right? The counseling, and just plug in the date, the patient's age, and then we can put in any of these topics we talked about. We got the little codes. We just plug in the codes that we talked to, and we use that health risk assessment to tailor our topics to that. Anything they answer on there that's kind of concerning regarding their health, well, then we can tailor our counseling to that. So more on health risk assessment and counseling. Health promotion. Per the United States Preventative Services Task Force, when we do health promotion, we should be talking about things like diet and exercise, dental health, tobacco, alcohol, substance abuse, heat and cold injury prevention, physical and sexual abuse, injury prevention, stress management, suicide and violence prevention. And we tailor this, we target it off of how they answered the health risk assessment. If they answered some things that are concerning, our counseling should be geared towards that. We need to be talking about family planning, okay? Whether or not the service member is planning on starting a family. And if they're not, what are they using for contraceptives? We've got to educate them on what contraceptives are available to them. And we've also got to educate them about, the HIV and sexually transmitted infection prevention and things like that. And we'll talk about unplanned pregnancy in a little bit here. We got to talk about medication and supplement use. These guys, we have a lot of our sailors and Marines that, go and they take all sorts of crazy pre-workouts on fat burners, and sometimes in the field environment, especially when it's really hot, those two things don't mix very well. If they are prescribed a medication, we should inform them that they should try to keep at least a 90-day supply. If it's a chronic a medication that they are chronically on, they should try to have a 90-day supply. And if they've got a deployment coming up, we've got to make sure that they know how to use the mail order pharmacy. So this is a graph I pulled up from the Navy Marine Corps Public Health Center. And we just read the title right here. Percent who said my last pregnancy while in the Navy was planned among Navy enlisted women. So just looking at the latest date we have on here, 2014, only 43% of the enlisted females who became pregnant were planning on becoming pregnant. Only 43% were planned. And if we look at the earlier dates, it's even worse. 37, 36% were planning on becoming pregnant. So those of you out there that have kids know, this is a major life-changing thing. So who knows what the status of these sailors were? Were they financially prepared? Were they emotionally prepared? Were they at a duty station that could support this, or did they have to get reassigned because of this? This has major implications. Not only that, were they on prenatal vitamins? Because things like folic acid have a small window in the beginnings of pregnancy where we really need that patient to be on it. So just something for you, an FYI, and just the kind of information you can pull off the Navy Marine Corps Public Health Center. So let's review a little bit of what we've gone over. What form is used to screen for tuberculosis exposure during the PHA? Just a routine screening for tuberculosis exposure. That's our NAVMED 6224/8. What is included in the readiness lab studies that require verification during the PHA? All right, so what is included, and we're talking deployment specific, okay? So what readiness labs do we have to do before we deploy? Well, we've got to have an ABO blood type and an RH factor, right? We got to know your blood type and whether or not you're positive or negative for RH. We got to know your G6PD status. Like I said earlier, very important for malaria chemoprophylaxis. We've got to have a DNA specimen in the National Repository on file, and we've got to have your HIV lab up to date. What dental classifications are considered worldwide deployable? What dental classification is worldwide deployable? Well, that is class 1 and 2, leaving 3 and 4 to be non-deployable. What type of exam is the annual dental exam? What type of exam is the annual dental exam? That is the type 2 dental exam. Type 2 is our annual dental exam. What 3 forms are used, got to fix that one, used in the deployment health assessment process? What 3 forms are used in the deployment health assessment? Well, that's the DD 2795, the DD 2796, and the DD 2900, right? 2795, your pre-deployment health assessment, done no earlier than 120 days before the deployment. Your DD 2796, your post-deployment health assessment, can be done 30 days prior to your redeployment, or coming home, or 30 days after. And then your DD 2900, that's your post-deployment health reassessment, 90 to 180 days after you've gotten home. In what chapter of the P117, the 117, would you find guidance on female-specific health screening? What chapter in the Manual of the Man-Med would we find guidance on female-specific health screenings? Well, that will be chapter 15. Chapter 15. What resource provides guidance as to when to screen for colorectal cancer? What resource have we been using, not only for colorectal cancer, but it can give us some guidance on female-specific exams, who to get lipids on, and a couple of other things. What was that resource? Well, that is the Guide to Clinical Preventative Services, put out by the United States Preventative Service Task Force. All right, so still going on our components of the PHA, the physical fitness assessment. You need a PHA in the last 12 months in order to do your PFA. All right, so this is another instruction that this one is going to intersect with. All right, so physical fitness, it's a readiness issue. So a PHA required in the last 12 months in order for you to do your semi-annual PFA. It doesn't replace the PAR-FQ, the physical activity risk factor questionnaire that we have to do, that asks whether or not you've got bone or joint injury, or if you got high blood pressure and all that stuff. But as any of you, or some of you may have tried, if you're expired on your PHA and you try to go into PRIMS and do your PAR-FQ, it won't let you, right? You've got to have a current PHA on file. If a waiver is required for the PHA, the privileged provider needs to document that on an SF600. So some responsibilities we got to talk about. Well, service members are responsible for making and keeping their PHA appointments. It's on them to make it and keep it. The unit's commanding officer is responsible for ensuring that their service members comply with the PHA requirements. And medical is responsible to ensure all members involved in the PHA process meet necessary level of training. You got to make sure that everybody who's in this, who's involved in it, knows what they're doing and is trained to do so. So certain roles during the PHA, any member of the healthcare team can do the following. They can identify service members who will require a PHA in the following month. They can send a list of those ID'd or to designated command representatives, right? So they can send a list of people who have been identified as needing a PHA to the designated command representative monitoring the PHA compliance. They can make sure that they can screen for health record or dental records to see if there's any, if they can identify any deficiencies. They can create itemized lists of components necessary to complete the PHA, and they can input data into the approved electronic database. Hospital corpsmen and above may do the following. They can do a blood pressure measurement. They can do the height, weight, and body mass index. Remember, it's actually got to be measured. You can't just take their word for it. They can do the visual acuity testing. They can do the immunizations. They can do any phlebotomy if they need to draw any blood for any of those labs. They can administer the heart, the health assessment risk tool. And they can do the health risk prevention and promotion. The health risk prevention and promotion and preventative service counseling. So they can do all the counseling on tobacco use, alcohol use, and injury prevention and all that stuff. And they can do the appropriate documentation for all the stuff mentioned above. Approved providers like your IDC, your physician's assistant, your nurse practitioner, and your physician. Well, they're going to perform the final review and signature of the PHA. They're going to make recommendations to resolve any health-related issues. They're going to perform the PHA and all service members who identify health issues. So if the corpsmen are going through and they're doing it and somebody identifies a health issue, this is one where the provider needs to step in and perform the PHA. They need to track to conclusion any unresolved deployment health-related issues. They need to make and document appropriate referrals as needed. And then they got to do their appropriate documentation. So most of the time your PHA is going to be done electronically in Alta. There still is the paper method available, and just like a lot of times you'll see the form is listed just like the instruction. It's a NAVMED 6120/4. Your IMR elements need to be documented in MERS and SAMS, DINCAS, and Alta. So resources available to you is per the instruction anyway, is a Navy Environmental Health Center PHA website, but now you'll actually find that on the Navy Marine Corps Public Health Center. So right here, this is just a picture of a screenshot of the Navy Marine Corps Public Health Center. And if you go under providers here, you'll see a tab that says population health, and there's that you click on that and you can get to the PHA, and it's got all sorts of resources. So if you do PHAs and you find you don't know what you're talking about really when it comes to counseling, or you don't have good talking points when it comes to going over the counseling for that health risk assessment, you've got resources on here. There's a lot of good resources on this website. I'd advise you check it out sometime. So let's review what we've gone over. Visual acuity worse than blank requires referral to optometry. 2040. Visual acuity worse than 2040. Got to go see optometry, get some glasses. What is utilized to test your distal visual acuity, your distance binocular visual acuity during the PHA? We got to use the Snellen chart. At what age is near binocular visual acuity testing required during the PHA? At what age is near binocular visual acuity testing required? When do we got to test near vision? When you're greater than 45 years old. How far is a near acuity card held when testing near vision? How far is a near acuity card held when testing near vision? 16 inches. If a service member requires corrective lenses, what medical equipment must be verified during the PHA? If you've prescribed glasses, what do we need to make sure you have? We got to make sure you've got 2 pairs of eyeglasses. We've got to make sure you've got protective gas mask inserts. We've got to make sure you've got your ballistic inserts as well for your ballistic eye protection. What form will you find the reference audiogram on? What form is a reference audiogram? Well, that's your DD2215. DD2215 is a reference audiogram. What immunizations are required for deployment? What immunizations are required for deployment? Hepatitis A and B, inactivated polio vaccine, your tetanus, diphtheria, and pertussis, your measles, mumps, and rubella, and your influenza. These are the minimum immunizations for any deployment. These are required for any and all deployments. Then, of course, keep in mind region-specific areas will have more requirements. What are the 6 elements of a service member's IMR? What are the 6 elements that make up somebody's individual medical readiness? Well, we've got individual medical equipment, things like our red dog tags, hearing aids, our glasses, dental appliances. All right, immunizations. Well, we just talked about the immunizations required to deploy. Our laboratory studies like G6PD, making sure our DNA is on file in HIV. Our dental readiness, our deployment limiting conditions, right? We can't be on a LIMDU status, pregnant, postpartum, or pending a PEB, physical evaluation board. And then, of course, our PHA, 6 things that make up our individual medical readiness. With our active component, what has the PHA replaced? With our active duty, what has a periodic health assessment replaced? Well, it's replaced that 5-year physical. What form do we do physicals on? DD 2808. What are the approved electronic systems that periodic health assessments and the components can be documented in? What can we document PHAs in? Well, we can put them in Alta. We got to put the dental part in DENCAS. We can put them in SAMS, and we can put them in MERS. Who is authorized to review and sign a PHA? Who's authorized to review and sign a PHA? Well, those are your independent duty corpsmen, physicians, nurse practitioners, and physician assistants. What form is used to screen for tuberculosis exposure during the PHA? Well, we're going to use our NAVMED 6224/8. What are the 2 other forms? Which one do we use when somebody is initially positive on that PPD? That was our NAVMED 6224/7. And what do we use for our monthly evaluation when we're treating somebody for latent tuberculosis infection? Well, that's our 6224/9. Right. /8, though, is just a routine one we do to assess for somebody's risk of being exposed to TB on our PHA. What is included in the readiness lab studies that require verification during the PHA? All right, what readiness labs do we need to look at before you deploy? We got to know your ABO blood type and RH factor. We got to know your G6PD status. Like I said, very important when it comes to malaria prophylaxis, our chemoprophylaxis. And we got to know your DNA specimen, and your HIV needs to be up to date with the last 2 years unless otherwise indicated. What dental classifications are considered worldwide deployable? Class 1 and 2, 3 and 4, not the case. What type of exam is the annual dental exam? We call it a type 2 exam. What 3 forms are used in the deployment health assessment process? What 3 forms in the entire deployment health assessment process are we going to use? We got the DD 2795, the pre-deployment health assessment. Our post-deployment health assessment, that's going to be your DD 2796, and your reassessment, that's your DD 2900. We do the 2795 120 days prior to deployment. Our 2796, we've got that 30-day plus or minus on the redeployment, either 30 days before we come home or 30 days after we've come home, and then the reassessment, 90 to 180 days. In what chapter of the P117 would you find guidance on female-specific health screening? What chapter of the ManMed would we get guidance on female-specific health screening? Well, we can find that in Chapter 15, Physical Examinations and Standards. What resource provides guidance as to when to screen for colorectal cancer or when to do a lipid panel on somebody? That would be our Guide to Clinical Preventative Services, published by the United States Preventative Service Task Force. That was a bit of a long one, but like I said, it ties into a lot of other instructions. I hope you found it helpful. This was SecNav Instruction 6120.3, but we also talked a little bit about OPNAV Instruction 6100.3 Alpha, which is your instruction on deployment health assessment. Like I said, it's on the bib. We talked a little bit about OPNAV Instruction 6110.1 Juliet, and that's on your physical readiness program, right? We talked about BUMED Instruction 6224.8 Bravo, tuberculosis control. We talked about the manual of the medical department, Chapter 15, physical examinations and standards. And these are all question-rich instructions. Okay, there's a lot of questions get pulled from these instructions. I would study them together, see where they interlink, like I said. And if you're just curious about a lot of the data and information I got, just visit the Navy and Marine Corps Public Health Center. They have a section on there dedicated entirely to PHAs, if you're interested in that. Like I said, I really hope this helps. Good luck on your guys' advancement exams.